We're going to go ahead and start with the questions while you enjoy your lunch. Please feel free to move around, go get seconds, go get a cookie if you feel the need, it's casual. If you have another question that pops in your mind, just raise your hand and we'll have someone come bring you to the front. We also have questions that were submitted over the Zoom for our audience at home, and we'll answer those as well.
All right, so the first question I have here is there any particular reason you would use safinamide over the other older MAO inhibitors? So based on data, at least from the different clinical trials that looked at the safinamide and the other MAO inhibitor, rasagiline, the data doesn't really, there isn't any data to compare the two, right, to see one is better than the other. But we do know that they both help with on time. So they both help increase on time, and they've measured different measures, so they're not one-to-one comparison. So I would say there isn't any data to tell us safinamide is better than the other ones, specifically for any particular symptom.
All right, so I'm not sure who asked this question, but I love it. It says, what if someone has the SNP, that's a single nucleotide polymorphism that links essential tremor with Parkinson's disease, REM sleep behavior, high blood pressure and restless legs, and the evaluation, if they're on the medication, masks their symptoms? And do we need better biomarkers? So I like the question. It's very specific, so whoever asked it, hooray, this is really good. The reason I like it is because I think it goes to, we call biomarkers of disease. And of course, biomarkers are anything that we can measure. Like where you guys come into our clinic, we do exams, we do measurements and rating scales. We also watch you walk and we rate those things. Those are measurable. We also sometimes take blood draws and we measure things in the blood. From blood, we can get things, actually other sort of cells, we can actually look at your genetics and what's being expressed. So this question has something to do with the genetics. And we do have a program here at the University of Florida. We are looking at genetics. We are learning that there are genetic factors, very rare causes of Parkinson's disease, even essential tremor. Many genes that we have 20,000+ genes that make up or encode our entire body. Many of those genes actually are risk factors. So they may not be direct causes, but they may increase your risk. So you're born with these things, or got them from your mom and your dad. You can't change these things, so it sort of loads the gun. And so we're learning a lot more about this, more and more. So basically, we'll tell the person who asked the question, really, we are really interested in biomarkers for disease. We're really interested in genetics, and we'd love to have folks participate in the program, and we're going to grow this as we go on. It gets very complicated quickly. In terms of evaluation, yeah, we have all of you, if you've been a new patient in our clinic, we have you come off medications. That just helps us see the symptoms. When you're not taking the medicine, we have a better chance of seeing that tremor or that shuffling gait. So if you take medications the first visit, it can mask some things, but it's not a big deal for us. We do repeated evaluations. That's the good thing about Parkinson's disease and following patients. We love following you guys and seeing things. And what we do is we correlate or compare those symptoms with what we see in blood or other markers. And biomarkers are great because we hope to learn something about the risk of disease. We'll learn things about how to diagnose you earlier, maybe about the risk for having future complications like REM sleep behavior, future dementia, or other complications of disease. So that's what's so interesting about this. And I think on the other end of this too, we also learn to use some of these biomarkers to actually assess how new drugs or new treatments may be helpful to you. I think most of you don't want to wait 20 years to find out whether a drug's working. So sometimes we use these biomarkers as a surrogate marker to figure out whether a drug is working, and we can detect things really early, maybe within the first weeks or even the first year. So a complicated answer, but a really good question. Thank you so much.
And I want to share that Dr. Tansey, who talked about the gut in Parkinson's, is still on the Zoom with us. So if you have questions for her that we weren't able to answer during her session, feel free to send those up.
One question said, study that collisions caused by fast drivers over the speed limit coming up on slow traffic determined optimal speed was 55. Any details? So On that specific study, no, I don't know that I've read that study, but I think the biggest thing that traffic has definitely shown is that it's the disparity between the speeds. So if you have very fast drivers and very slow drivers, that's where you run into trouble. It's, speeding in and of itself, no, that's not a good thing, but if everybody's going the same speed, then there's less trouble than if there's a mixture of fast and slow traffic. So that's one of the challenges is if we can't change the people that are going a certain speed, particularly if they're driving close to the speed limit, then someone else driving significantly under it while still legal, that's where you're running the risk is that mixture.
Okay, so one of the questions was, what about Parkinson's and the skin? What do they have to do with one another? So there are at least two things that are relevant in Parkinson's and the skin. One of them that is specifically written here too is skin cancer. So there is an increased risk in melanoma in individuals with Parkinson's disease. And so it is important, especially for us living here in Florida, to have your skin checked. And if you've experienced a skin cancer or something abnormal even more frequently, maybe every 6 months instead of every 12, it is important. The other thing is Parkinson's can be associated with a skin condition called seborrheic dermatitis. Some people may have heard of dandruff, and that's one symptom of seborrheic dermatitis. But this is an irritation of the skin. It can look red and oily or flaky. It's often under the scalp, under the hair, but also can be on the bridge of the nose and behind the ears. And this is a treatable and manageable condition. Most primary doctors are comfortable advising there are over-the-counter products and different shampoos that can work, steroid creams that can work. And those are things that are more common in people with Parkinson's disease.
Sure. So welcome everyone. It's great to see the group here, and then also the group of 60 that are on the Zoom. We are approaching our 20th year together, so you all have been doing amazing work. This is number 20. Okay, I'm getting old here, but I will tell you that it's great to be sitting on the stage with a group of interdisciplinary professionals. So we orbit around you. Okay, two questions here. Are there multiple variants of dopamine or just one flavor? And then also there's a recent paper from the National Academy of Sciences talking about restoring brain networks, what are called striatal networks, but networks in brain using deep brain stimulation of things like the subthalamic nucleus. And those two things really go together, those two questions, even though they're from different people. First of all, there are different locations in the brain for dopamine. Okay, you should know that. There are a few flavors of how dopamine works. And so it's a chemical that's in the brain, but it can be in multiple circuits. And the thing to remember is that dopamine functions a lot in reward, okay? And so it lights up when you have a lot of reward or impulse or learning. It also lights up in learning as well. And that's one circuit. The circuit we talk about and think about the most for Parkinson is the motor circuit, so for movement. But it turns out in Parkinson you can also get these other circuits, they call them limbic or behavioral circuits as well. And so there are multiple areas. And so that leads into the second question. So there's the flavors of how dopamine works. It's a single chemical, but it can work in multiple different areas of the brain. And then what we know now, so we're talking 20 years, from 20 years ago to now in our laboratories here and in others around the world, are that it's not when you do deep brain stimulation, it isn't just an on-off switch, like you push it into a little spot in the brain and the magic happens. Maybe we thought that for a while, but what we now know is that there's an entire network change. And the networks change, and as the networks synchronize, in different ways, you get improvements in different symptoms. And so we think of it as multiple brain regions synchronizing. Think of it as an orchestra. And so if the orchestra is in sync or the orchestra is out of sync, that's when you start to see changes. And we focus the orchestra a lot on our thinking of things like tremor and stiffness and slowness, but many of you have other issues like walking, talking, thinking. And so understanding how that orchestra is going to play and mood issues is going to be important.
So I have a question. In DBS surgery, can the electrodes be placed effectively if the patient is asleep? When is a sleep versus a awake placement option? So yes and no. A lot of centers do a sleep DBS placement. In our center, I think we tend to believe that our approach gives a better or has a better chance of a better outcome. So think about sort of the areas in the brain as like real estate. So it's very important in terms of where you stimulate in the brain, and a millimeter of a difference can mean a lot of changes. So when a person is awake and we do microelectrode recording, we can hear the different sort of cells or different groups of cells in the brain as we go down the pathway, and we can come up with a sort of individualized physiologic-based map that then we compare that map with the sort of anatomical map that the surgeons initially used, and then we make a final decision on when we place the lead, whether we want to keep that original plan or whether we want to make a subtle adjustment. Keep in mind that the sort of the anatomical atlas-based map are based on a limited sample of specimen, so the atlas don't always fit perfectly to your brain, and then surgeons, based on the atlas, is an estimate of where they put the leads. So when we do the electrophysiology recordings, that gives additional information that allows for a better precision of the lead placement and in turn better outcomes. But for certain conditions, a sleep placement is, of course, an option. Say for people with a lot of cervical dystonia where they cannot keep their head still, then general anesthesia is indicated to allow for the surgery. For children who cannot tolerate the surgery awake, and that can be done under anesthesia. And sometimes other specific considerations, including sort of extreme anxiety and things, can be performed with a sleep DBS surgery.
So this is a twofold question. First question, should PD patients take in smaller portions? And secondly, should PD patients chew food more than non-PD patients? So ultimately, swallowing is very individualized, so I don't think there's a blanket statement that I could say those with PD should eat smaller, chew more. We do know that in terms of chewing, sometimes that range of motion of the jaw opening is reduced because of those hypokinetic movements, those smaller movements from the PD. But I wouldn't say generally you need to avoid any foods unless you've had a swallow study or had some incident with a certain food. Some people also find that if they have dry mouth, they have to chew for a little bit longer because you need your saliva to mix in with what you're eating to soften it and keep it cohesive in a bolus, which is what you're swallowing. Same thing with smaller bites. I wouldn't say everyone needs to eat smaller bites. I think you have to consider the whole person in the situation. We know that distractions in a swallowing environment can impact swallowing. So if you're not paying attention, you might put too big of a bite in your mouth. Or if someone is impulsive, those cognitive changes, those can also influence the size of the bite. So sometimes we'll have to have caregivers or family members cut up the food if motorically it's too hard or if they just won't do it themselves.
The other question on driving was, does the driving study include good signage versus poor signage as a factor? So specifically, it doesn't include that, but for example, one of the features on the car puts up what the speed limit is, and it kind of keeps it up there in the corner of the speedometer so you can see it. But when we first turn out of Fixel onto Williston, there are no speed limit signs for a while. So I do tell the participant the speed limit is 45 so that they know, because it's not fair for me to say they're going too slow or too fast if they have no way to know what the speed limit is. So we do take that into account, at least with the speed limits along the route. Now, I'm not going to mention things like the lane ending or something like that, but signage like speed limits, if it's not present, then we do take that out of the equation and tell them.
All right, so our next question here is, can gastroparesis be a side effect of levodopa or is it a purely a manifestation of PD progression? So I'd say that this is one of these questions that it's a little bit hard to kind of know, really. I don't think that we have any data to suggest that levodopa itself may be causing the gastroparesis, although we do know that levodopa sometimes can cause some worsening of constipation in some patients, so it definitely has some effects with the GI symptoms that you might experience. However, I don't think that there's any study that's really looked at gastroparesis and levodopa specifically. Perhaps Dr. Tanzi might have some extra input into gastroparesis, but I think it's more of a PD progression symptom.
Dr. Tanzi, did you want to add any comments to that about Parkinson's and medicine and the gut?
I would say that, every person is unique, and we know that medicines do affect the microbiome and the, obviously the studies that are done for gastric motility and gut permeability. And so it's important to make sure that, if you're considering having those kinds of studies done, that you don't do like a snapshot in time, because a lot of times those factors are influenced by lots of different things that may affect the outcomes of those tests. And so you want to look for sort of a reproducible, feature that is there a lot, and not just, every now and then, because there's a lot of things that can affect the motility, the microbiome, et cetera.
So I have a question on the remaining, substantia nigra or dopamine neurons. Are they still healthy? And are they treatable? Can you bring them back to full function? So I think many of you might have heard some of us, at least we know in the lab, and we obviously can't do this on people's brains, but we know in the lab that by the time we see patients in our clinics manifesting with symptoms, that they have at least 50 to 70% loss of dopamine cells just by the time you come into clinic. So it's pretty impressive. The brain can compensate for a lot, but you reach a threshold where symptoms manifest and you need to see your physician, need to be treated. So what about the other, let's say 50 to 30% of those neurons? What are they doing? And what can we do to keep them healthy and functioning? I think first I would just say, the current state of affairs, our medications that we give you, like levodopa, are symptomatic medications. That's one class of medicines. They treat symptoms. They aren't, as far as we know, we call disease modifying. They're not protective per se, okay? However, I would say, we do have some really exciting, progress recently in the last several years. And there are new trials that are growing and increasing in numbers that are looking at what we call DMT, we call those disease-modifying therapies. So disease-modifying therapies are therapies that would target those remaining neurons and protect them in some way. And in fact, I guess the hope really would be to either re-energize them or even to produce new cells. That's just another additional step, of course. We want to keep you as healthy as possible and keep those brain cells working as long as possible. So a lot of this is experimental. There are some medications that are out. You talk about blood pressure medicines. Isradipine was one blood pressure medicine. It's a calcium channel blocker that supposedly affected some of the remaining dopamine cells, converted them to a younger state that maybe made them function differently. The question, of course, has always been, does it make that big of an impact? It doesn't appear to make a huge impact in patients who take that one particular blood pressure medication. But it's one example of a currently approved drug that people have tried and used. So what else can you do, really, to protect those cells that are still left? What I would say is really, I think the thing that we always talk about is exercise and activity helps everybody's function, helps keep those cells alive and make them function. Enhances their function, actually, and gives you sort of a boost when you do exercise regularly. So things that you can do. I wish I could say there are specific vitamins and things that can be used. I know we've done lots of different studies over the many years, some really large, that have looked for supplements that may keep these cells still alive. Yeah, they might do that. We're still trying to examine whether they actually have a true effect on patients. But I think the really great thing is actually looking at new trials and new drugs that are actually coming out that are there. The new disease-modifying therapy, that is the next stage in our treatment of Parkinson's disease, and that's exactly what we're going to do. Keep these cells alive and healthy and even improve their function to help you.
Okay, so the next question is about protein and the impact on medicine. So the individual specifically said, I like to take protein shakes. I like to work out. You guys keep telling me exercise is important. I know it's always been important to me. How do I deal with that? And the question that comes up is that some people will find that when they eat a heavy protein meal, it makes their medicine less effective. Some people even say that it makes it feel like my medicine didn't work, or it negates that dose of medication. And the reason is that protein is absorbed in the same regions where our levodopa is absorbed. So we don't want you to avoid protein. This is an important part of a balanced diet, and we should be able to eat protein. But what you can do, if you find that you're sensitive to those effects, and you find that when you eat with your food, with your medicine, it's less effective, you can adjust the timing. So you can take your medicine, give it a head start. So take your medicine 30 minutes before you take the protein, or you can take your medicine 2 hours after you've eaten the protein. And a lot of times a small amount isn't a big deal, but if you eat a nice juicy steak, you might really feel that. When people have early and mild Parkinson's, they often can take their medicine right with their food, and it's even encouraged so that it doesn't upset the stomach. It's easy to remember. But the longer someone has it, it may be more important to absorb every little bit out of each dose of medication. And in those cases, separating from the protein load can help you continue to benefit from the dose.
Yes. Okay, so a couple of things. One, I want to reassure anybody that has like really crazy changes in your body temperature, where you get super cold and things that didn't happen before you have Parkinson. I want to just say, yes, that can happen with Parkinson. So I want you to feel validated. And I see that question coming in here because you can definitely get what's called autonomic nervous system symptoms. Some people call it the automatic nervous system, and those affect things like temperature, but also blood pressure, okay? And there's another question here about blood pressure, and so I put those things together as well. You can get low blood pressure, and a couple of pearls, things you can put in your pocket when you leave here. One is the blood pressure can go down just from having Parkinson itself. It is in some ways a silver lining of Parkinson, in that some people will be able to come off of their blood pressure medications or reduce them with Parkinson's disease because it tends to bring the blood pressure down. Okay, so that's the first thing to remember. The second thing to remember is the medications, dopamine medications, can also bring the blood pressure down. So you can imagine if the Parkinson itself can bring the blood pressure down and the dopamine medications can bring the blood pressure down, and then you're on a high blood pressure medication, it's like the big three, right? Be careful, okay? And so that's why your medical team will always tell you drink 6 to 8 glasses of water a day. They'll tell you use abdominal binders and stockings if you can, although a lot of people think the abdominal binders you can buy in the drugstore are easier to use than stockings and maybe equally as effective. And in some cases, taking some medications if your blood pressure is getting low, and usually the symptom is lightheadedness.
So I have a question on focused ultrasound. Exactly how small can the focus of ultrasound be? So the focus of the ultrasound, depending on the transducer, can be as small as 1 by 1.5 millimeter to as large as 10 by 16 millimeter. But keep in mind that after they create the lesion, there's also swelling, so that can appear larger depending on when they get the imaging. And over time, there's a sort of scarring and sort of modulatory or remodeling effect of the lesion. So in clinics, sometimes when we see someone who had focused ultrasound before, we may see nothing or like very tiny hole on the MRI, or we may see a pretty obvious and sizable hole. So how big it's going to be over time, it depends on each person's specific anatomy and property.
So, a question for Alana. In healthcare, it's often said that we should have an advance directive, which is a statement of if I can't speak for myself, who should you ask the answers about what I would want you to do or not do, or what's important to me if my health would become really troubled and I couldn't tell you what I want? And can you give advice about if someone wants to have an advance directive, what would be a good first step to take, or any options of how they can get one of those written?
So those forms are easily found online. An advance directive of a living will is not a legally binding document. What it is something written out if you are not able to speak for yourself and the family members are in disagreement about what mom, dad, brother, sister wanted. That document is a clear statement of what they do and do not want. A healthcare surrogacy form can also be found online. Those are more legally binding when those are signed by two witnesses. And it is always a good idea for someone to have both a living will and a healthcare surrogate in place, regardless of your age, regardless of your health condition. I come from a hospice background. Many people have accidents unexpectedly happen to them. And the family has never openly discussed this before about what they might want to have happen if something unexpected like that happened. So there's a movement on in America to have discussions like this at Thanksgiving of all times, because that is when family is together and everyone can discuss that because they're there and hear it from mom and dad or from someone else. And it can be a way to open up the discussion. It's a hard thing to talk about. Sometimes it takes more than one discussion. But I would suggest that everyone have that in place. And it's good to talk about things ahead of time before it's an emergency. Yeah.
And for Nicole, besides, if I have a hard time swallowing pills, besides switching to non-pill forms, do you have any advice for helping get my pills down?
This is a very common question. So I always say that there's a big spectrum of pill taking. So you can ask probably 20 people without Parkinson's disease, and each one would tell you something different. Some people would say, oh, I can toss a handful in my mouth and swallow it without water. Some people say, oh, I can't take pills at all, or have to toss my head back. So generally, we recommend a few things. So pushing pills further back in your mouth can be really beneficial. People tend to just dump a pill in the front of their mouth, and then it has more room that it has to get back. Another good strategy is taking one pill at a time or a few at a time. If you tend to take 10 at a time and one gets stuck, maybe try 5 at a time, or maybe try 2 at a time. And then lastly, we are big fans of putting pills in like applesauce, yogurt, pudding, mashed potatoes, something thicker, hiding the pill in it, and then trying to swallow it down as one. I will tell you, some people will swallow the good stuff, they'll swallow the pudding, and the pill is still in their mouth. So something just to consider.
So I'm going to try to answer this question. This is actually for Dr. Ostrom, but it's asked about diabetes and a medication change, and I'm not sure if the medication listed here is correct. And I'm wondering if you're thinking about exenatide, which is a current diabetes drug. So maybe diabetes and Parkinson's. There certainly is this thought of a link between, so some types of diabetes, particularly type 1 diabetes, is an autoimmune disease. Type 2 diabetes is a little bit different, which usually is a more adult onset and related to sometimes body habitus as well. But the drug exenatide is an injectable medication given for diabetes. And there is some evidence that exenatide has some effects on Parkinson's disease. There was actually a study published on it. It's a modest effect. And so the questions come up really, does exenatide exert a protective effect, okay, on the brain? So this is, again, kind of related to saving these brain cells, because there is some evidence in the lab about this, okay, in animal studies, or we call preclinical studies. So I would say the jury's still out. We are actually doing a study here at the University of Florida with Dr. David Valancourt in his lab We're looking at patients with Parkinson's disease who are being treated with this drug exenatide and looking at changes in the brain using a brain scan called an MRI scan. So just wait. We hope to get some more information. We're still enrolling. So hopefully we'll have an answer for you, at least part of the answer for you very soon. Great question. Thanks.
Well, that is it for the questions we received in person and on the chat. We're so grateful that everybody came out today. We're happy to be together in person, and we're happy to have an audience that's joining us from home too. Whatever talks you weren't able to sit in person with the 2 rooms, you can catch after the fact. They'll all be made available on our YouTube channel. And we hope that everybody enjoys the rest of their weekend.